Caregiving can feel overwhelming. Some days feel impossible. If you're caring for someone with Alzheimer's or dementia, we want you to know this. You are not alone. There is help. There are resources. And there is hope. This is GutPunched, Alzheimer's and Caregivers. Greetings and welcome. This is GutPunched, Alzheimer's and Caregivers, the not-so-sexy podcast, episode 86. Welcome. Glad you're here. I'm Jeff Edwards, your host for GutPunched, Alzheimer's and Caregivers. We hope you had a good week, and if you're getting pounded by snow, I feel for you. That's why I moved to Florida from Oswego, New York, all those years ago. You know, they still haven't uncovered my 73 Nova. I'd like to say thank you to all those who reached out regarding our last episode about hope. It was very much appreciated. It seems that a lot of our listeners deal with this issue frequently. It ties into so many things when you're a caregiver. Greetings to our sponsors, Heart, Body, and Mind Home Care, and a very warm welcome to our new sponsor, NPRC, which stands for Neuropsychiatric Research Center, a clinical trial center dedicated to advancing research and treatment for memory loss and Alzheimer's disease. These people are the real deal. So today, we'll begin part one of our conversation with Dr. John Huffaker from the Neuropsychiatric Research Center. He'll tell us what NPRC does and explain what the p-tau217 test is and why it may change how Alzheimer's is detected earlier than ever. What I really liked about our talk is that he brought it down to a level that was so very easy to understand. I think you are going to enjoy this. He provided so much important information, we couldn't fit it all into one episode. So we'll air part 2 next week. Plus, we're going to introduce a new feature called What's New in Alzheimer's with Dr. John Huffaker. We have our first 2 listener questions, and they will be answered by Dr. Huffaker. If you have something you would like to know more about and answered by the doctor, you can send them to us at gutpunchedac@outlook.com. If you're new here, these 5 tenets are the backbone of everything we do. They're simple, but very important. Number 1, you must take care of yourself, because if something happens to you, who is going to take care of your loved one? Number 2, you can't do it alone. You need help. Find good caregiver groups or network with friends or relatives. Number 3, make a list of friends, relatives, or coworkers who have offered to help you in time of need. And then make a list of things you need done but can't do yourself because caregiving duties are overwhelming. Use the lists. Start at the top and keep going till you get what you need done. You'll find it very helpful. Number 4, create a help signal. Identify a cue or phrase to confirm your loved one is comfortable with receiving help. Make it something your loved one can remember. Now, this is for when you have caregivers outside of family helping with caregiving duties. It will help put them at ease. And number 5, caregiving. Love it or hate it. It will be your life until it's not. So give it your all.
We'll be right back to GutPunched, Alzheimer's and Caregivers.
Your brain is who you are, your memories, your personality, your life. At the Neuropsychiatric Research Center, they're committed to helping you protect it. If you're 50 or older, you're invited to our free memory screening event where you can learn about a breakthrough in early Alzheimer's detection, the p-tau217 blood test. This cutting-edge test may detect Alzheimer's-related changes earlier than ever before and is offered only to eligible participants based on screening results and family history. Why call? Because a quick confidential memory check can give you peace of mind, help you establish a cognitive baseline, and connect you with research opportunities that could change lives, including your own. Call Neuropsychiatric Research Center, located in Fort Myers, at 239-939-7777 to schedule your free memory screening today and see if you qualify for the p-tau217 blood test. That number again, 239-939-7777. Your brain matters. Let's protect it together. The p-tau217 blood test is available only to participants who meet eligibility criteria determined during screening.
This is GutPunched, Alzheimer's and Caregivers.
Our podcast continues to grow each week. Thank you very much for that. Now, if this episode helps you, please share it with one person who needs it. You can just send them a link or send them to GutPunched.com. Maybe they need the information and resources. Let them know they're not alone. There is help and hope out there for everyone. There's that hope word again. If you like what you hear, please subscribe to the podcast. It's easy. Just push the subscribe button. Are you ready? Let's go.
What's new in Alzheimer's with John Huffaker.
John, I got an email from Don W. in Port Charlotte, Florida, and he wants to know what is the difference between Leqembi and Kisunla, and which is better?
Don, we get asked that question all the time, and to be honest, there isn't a real huge difference between Leqembi and Kisunla. They're both the same class of drug. That class of drug is an amyloid-modifying monoclonal antibody, which basically means those drugs pull off the excess amyloid that builds up on the brain of Alzheimer's patients. And Leqembi and Kisunla are similar medications that are made by two different manufacturers. Couple little differences. Leqembi, it is an IV infusion that you have to get done every 2 weeks, whereas Kisunla is also an IV infusion, but you only have to do it once a week. I kind of describe these medications. I tell patients these medications, they're good, but they're not great. It's the best that we have right now that's been approved by the FDA, and they definitely have a value and a place. We just need to introduce them early on. Sometimes I describe it as like, okay, there's different kinds of cars. There's Chevys, there's Fords, there's Toyotas. You might like one a little bit more than another, but they're all basically the same kind of car. There's no Ferrari hidden among them. And that's the same way those medications are. They're very similar, not huge difference, just different manufacturers. We have used them and studied them for years and years at NPRC. We're still doing some clinical trials with both of them. Truthfully, if somebody will say, which one would I take or which do I think is better? Honestly, probably the best one is whichever one your insurance will pay for. Bottom line comes down to it is whichever one you can get your hands on is probably the best one to take.
All right. We have an email from Christine S. in Cape Coral, Florida, and she says, my spouse is starting to forget a lot of simple things like addresses, names, and people. What should I do about this?
And that's another good question. This is something that we get asked all the time, and it's becoming more and more common. I think that people recognizing that the memory and cognitive difficulties of our loved ones and spouses is getting to be more prevalent, and people are talking about it more. So it's a good question. And really one of the first things I would tell anyone to do is talk to your primary care doctor, your family doctor who you go to. And there's a couple of simple tests that they can do. Usually that's something they do once a year already. It's pretty basic, but it kind of helps them identify some things. And then from there, they can always help to direct what is the next step. Do they need to recommend you go on to a specialist? You go see a neurologist for further evaluation? They can help on there. The other thing that a lot of times that we do at NPRC, it's the other part where I step in and I tell people part of what we do is we do free memory screens or cognitive testing for anyone in the community. And the advantage of that is, one, is it's free. We don't take money. We don't take insurance. So we do it for free. And we can do a little bit of a workup and then make a recommendation from there. One advantage of that too is we have lots of people that they come in once a year. They're cognitively, their memory is pretty good. Or they've noticed a couple little subtle changes, but they really didn't want to do anything at this time. So they come in once a year and we do that memory assessment, and now we have something to work off of. We have a baseline. That's why I say it's important, even if your family doctor does some sort of basic testing, because it's very difficult to kind of determine where somebody is when we don't know where they started. So if you can get some of that baseline testing in, doesn't need to be anything complicated, it kind of helps guide us down the road, because we're all individuals. We kind of have a rough idea, even based on our age. Where should we be functioning cognitively? Of course, we have a rough idea, but everyone's different, and it's very helpful to get that baseline, and then they can kind of help guide and direct from there.
Great. Thank you very much. John Huffaker, DNP, FNP-C, Principal Investigator, is board certified by the American Association of Nurse Practitioners. He has over 15 years of research and clinical experience dedicated to the field of aging. Dr. Huffaker has been a clinical investigator on over 30 clinical trials for Alzheimer's disease, dementia, and related neurologic disorders. John has earned degrees from the Ohio State University, Kent State University, Ohio University, and the University of South Florida. In his free time, John and his family enjoy traveling, spending time outdoors, and faceting gemstones. Welcome, John. How are you doing today?
I'm doing great. Thanks for having me. It's a pleasure to be here and get a chance to talk to you further. I kind of wanted to maybe expand a little bit of what NPRC is. NPRC is the Neuropsychiatric Research Center. We're located in Fort Myers, Florida, and we're a little bit different. We're a standalone clinical research facility. So all we do are clinical trials. The vast majority of our clinical trials are focused around Alzheimer's, memory disorders, cognitive function. We do a few other outliers. I don't have a clinical practice. So all we do is clinical research. We do not see patients privately. We only conduct research here. So we work with a lot of the other providers in the community when they'll see a patient that for whatever reason they think they would be a good candidate for clinical research, or they would like to get our input and have us do an evaluation, they'll refer those patients to us. The vast majority of the way we get clientele, the patients that come into our clinical trials, one of the advantages of what NPRC offers, since we're doing only clinical research, we don't charge any money. We don't take insurance. Everything we do is free. So some of the medical doctors in the community like to kind of use us as an evaluation or an entry point because they can get a workup on their patient at no cost. And then we discuss it with them, get back to them, and kind of figure out what's the best next step for those patients. We also have lots of patients that come and see us just on a yearly basis for kind of a memory check. We do free memory screens as well. So we'll evaluate anybody, do a quick little memory assessment, kind of get a baseline and also get some findings from there and kind of determine what they do. To be honest, with clinical research, it's not for everybody. And we understand that. Clinical research, it's a big commitment on both sides. It's a big commitment for the patient going into the clinical trial. It's a big commitment for us of what we do on our end as well. Probably the majority of people that come and see us don't go into a clinical trial for whatever reasons. Sometimes they don't want to. Sometimes they're just not a good fit. But part of what we do is we'll do that workup, and we also go over and discuss with them every treatment that's out there. If we see a patient that they come in and there's a few medications that have now been approved by the FDA that are an option, they weren't there a few years ago, right? Well, if we've used those medications here for over 10 years, so we're very versed with them. If we see a patient here and we're assessing them for clinical trial and they look like they'd be a good candidate for one of those medications already approved by the FDA, we'll encourage them to look into that and to consider doing those medications first. And if for whatever reason they don't want to do those medications or they don't qualify for those medications, then they could look at clinical research. We try to always advise somebody on what is the most logical step for them to do. And it's not always research right off the bat, but also sometimes it is. And I know that's a long-winded answer.
That's great because it explains everything. Now, I understand there is a testing going on for p-tau 217. What can you tell us about that?
I'll have to go back a little bit in order to go forward, but it will make more sense kind of when I'm done explaining it. So the p-tau 217 is a blood test, and it's a blood test that has now come available. There are two different p-tau 217 blood tests that have been approved by the FDA in the last 6 months. But what that blood test does is able to correlate the amount of amyloid protein that is built up on the brain based on that particular blood test. So if we go back in time, why that matters is the amyloid protein is what we use to make the definitive diagnosis of Alzheimer's. That is the pathology that we know is there. So going back in time, when we first started looking at and studying Alzheimer's, the only way you could truly diagnose Alzheimer's was on an autopsy. And you've probably heard that before.
Yes.
So what we literally did is we looked at brain tissues and we looked for the presence of that amyloid protein. That was a little too late, but that's where we learned from it. From that point, we knew we needed to find something quicker, more accurate. So that led to analyzing cerebral spinal fluid. So that was done by a lumbar lumbar puncture. So we could do a lumbar puncture, and by doing the lumbar puncture, we analyze the cerebral spinal fluid, and we can detect the presence of the amyloid protein. So that's something we could do much sooner in time, intervene much earlier. The negative to it is still lumbar puncture. It's a procedure. We're putting a needle in the lower part of your spine. People don't like to do that. So it evolved from there to where we came up with PET scans. So we can do a PET scan specifically looking for either the amyloid or even the tau protein, but we can do that type of imaging. The advantage of it is you just kind of lay there and we take a fancy, high detailed picture of the brain and we can look for these amyloid proteins. The negative, it's expensive and there's some limitations. One of the limitations is it uses a tracer. We put an injection in of what we call as a tracer that's attracted to the amyloid proteins, and then we take a fancy picture of the brain, and the proteins kind of light up like a Christmas tree. We can see where that amyloid is on that picture. The problem is that tracer that we have to use only has a shelf life of about 8 to 10 hours from when we manufacture it. So there's certain parts of the country in the U.S. they cannot get that tracer to them fast enough. As an example, all of Hawaii cannot do an amyloid PET scan. They have to fly to California because they don't produce that tracer in Hawaii and they can't get it there fast enough. It goes bad. Fortunately, here in Florida, we have 2 production facilities. One is down in Miami and the other is in Tampa. So we get them pretty easily. Years and years ago, when we were doing PET scans for research that weren't available any other way, we would fly our patients from Fort Myers here up to Baltimore and have them stay at the night because that was the closest production facility, and we learned it was easier to have the patient there ready to go when they produced the tracer than it was to try to produce the tracer and fly it here. Much improved, that's getting much better, but there's still limitations. So the great advancement with that p-tau217 blood test is now we have a blood test. We can draw a little bit of blood, we can test it, and it can give us, with a high accuracy, depending on which test you use, they're all in the 90-some percentage of being able to correlate to what that amyloid PET scan would show. So now we can do a blood test. Imagine how much more readily we'll be able to identify individuals with Alzheimer's that have with the ability of this p-tau217 blood test. One of the things is why that's important, and it's probably been discussed, and you've heard it on other talks before, but these proteins start to build up for 10 or 20 years before there's ever even a symptom. So imagine if we can do this blood test, and this is me thinking not too far in the near distant future. I don't know, when we turn 60, part of your yearly workup is this blood test. And maybe you do that every year. Now we're going to be able to identify individuals that have the building up of these proteins sooner, more accurately, and then we'll be able to initiate treatment. So I sometimes tell people the ability to diagnose it is just as important as the ability to treat it. Because if you have a treatment, but you really can't identify people very readily, what's the point? So I think this p-tau blood test, so we call them blood-based biomarkers, but it's really a fancy way of saying a blood test. I think that's going to be game-changing for diagnosing and treating Alzheimer's. It's just going to open the field up so much more accessible to individuals, and it's more cost-effective, going to be much more readily available, and that there's 2 that are approved by the FDA now, and there's a handful of other ones that will be coming along. So like everything else, competition will probably only help make that even more readily available. So it's exciting to have this as an option for our trials that we have done over the years. We almost always have done this p-tau217 blood test, and then we verified it with an amyloid PET scan. So a lot of that data that they use to show the effectiveness and to dial in exactly how to use this p-tau217 test came from the clinical trials we were doing. We compared the blood test to the amyloid PET scans that we've had, and we've done it for years. We were able to tweak it to where it's a pretty accurate diagnostic tool. Right now, the insurance companies, and I have to preface this with saying I do research. I don't deal necessarily in the insurance world, but I'm familiar with it because I work with all the neurologists in the area that are managing their patients with the commercial insurances and Medicare. Right now, the insurance companies are not paying for that p-tau217 test to use it to determine if they could do a treatment like Leqembi or Kisunla. They do pay for it to determine, say, okay, we're testing to see does this patient have Alzheimer's. Then for them to do the Leqembi or Kisunla right now, they still have to follow it up with an amyloid PET scan or that lumbar puncture, like I mentioned. Mm-hmm. Those are considered the 2 gold standards for testing the amyloid protein right now. But that's going to change. They will start to accept that the p-tau217 blood test will also be used to be able to start the treatments, Kisunla into Leqembi, which will be helpful because you can just do it quicker. There's a backlog to get PET scans.
Yeah, I know with my wife, we had major issues with that. 3 times they put us off 10 minutes before we were supposed to be there. It took 3 months to finally get one.
Oh, yeah. Very likely that tracer might have gone bad.
I never thought about that because I didn't know about it, but that is interesting. Now, you talk about an amyloid plaque, and then you talk about tau. Is there a difference between amyloid and then tau? Because I always thought tau was what they call tangles versus amyloid buildup was something different.
Good question. So if you think about your body makes tens of thousands of different proteins. There are all sorts of different ones. Amyloid and tau are associated with Alzheimer's. They're present throughout the body, not just in the brain. But when you look at Alzheimer's, and we don't know why, we still don't know to this day, why does one person have a buildup of the amyloid and tau proteins and another person does not? We're not really sure what causes that, but when that does happen, that's how we can identify Alzheimer's, because those individuals have an excessive amount of the amyloid and typically the tau protein. So the difference between them are they kind of are located in different parts of the brain. They each are troublemakers in the Alzheimer's disease. If you read about Alzheimer's and you read about plaques, the building up of plaques, that is the amyloid protein. If you read about tangles, that is a result of the buildup of the tau protein. So they're both causing problems. They're kind of talked about together because there is typically a little bit of a correlation between amyloid and tau. Meaning as amyloid elevates, it also starts kind of the overproduction of tau, and that's how that p-tau test works. It knows if you have a certain amount of tau present by studying tens of thousands of these amyloid PET scans and comparing them, we know when you have this much tau, you typically are going to have this much amyloid. And that's why I said it's in the 90-some percentile, depending on which blood test they use. It's like 93 to 97% accurate to what that amyloid PET scan would show.
Gotcha.
So it's pretty dead on. But that's why we talk about the 2 different proteins. The current medications that are approved by the FDA can only treat the amyloid protein. They do not treat the tau protein. That is something we've been working on in research, and I think I currently are doing 4 different clinical trials that are targeting that tau protein. So we're trying to also reduce the tau protein. You know, I think one day we'll come to a point where we do kind of a cocktail of medications. I describe this, it's very similar to like with HIV. If you think 20 or 30 years ago, if you got HIV, it was a death sentence. Now, through a combination or a cocktail of medications, we've made it irrelevant. HIV, if it's controlled, doesn't advance to AIDS. As a matter of fact, we can get the viral load down low enough that you're not contagious. And we do that through a combination or cocktail of medications. We haven't cured HIV. We'll probably do the same thing with Alzheimer's. We'll have a cocktail, and it might not be a cure, but we'll be able to keep it at bay, make it irrelevant, reverse some of the damage that has been done. Part of that will be treating the amyloid as well as the tau protein.
I'm going to bring you back to NPRC p-tau 217 testing. You mentioned before that it doesn't cost individuals if they become part of your program, correct?
Correct. So what we're doing is I kind of ran through what that test is, what it intended to do, and we have used it for part of the criteria. So whenever there's going to be a clinical trial, the company that wants to do it, typically a drug company, kind of works out with the FDA everything in advance. They want to make sure, is the study truly neutral? Is it safe? And you have inclusion and exclusion criteria, meaning here's things that you're allowed to be into the study, here's things that make it so you can't be into the study. And we use that p-tau testing for years and years as an inclusion criteria, meaning we did that test to see, okay, you have the proteins there, so this is Alzheimer's, and that was what got people into clinical trials. Well, now that test has become FDA approved, part of what we're going to do at NPRC is we're going to offer that test to individuals without necessarily going into a clinical trial. We're basically going to give this test for free to individuals that want it. Now, we're going to have to control, so we can't test just everybody. There has to be a couple of criteria on our own end that makes sense to test individuals. One would be test people that feel as though they're having some memory issues. That's what we're looking for, some reported memory issues.
Right.
We want to make it an ongoing thing that we can do for individuals throughout the year, but we have to put a little bit of criteria to be able to get that done.
What should a listener do to get more information or get involved with NPRC? How do they contact you?
Probably the easiest thing to do is to call our office, 239-939-7777.
I want to thank John for talking with us today. He gave us a wealth of information. if you need to get a hold of them. That number again, 239-939-7777. Thank you, John, for your time.
Thanks for having me. It's been a pleasure, and I can tell you the passion in your voice when we're talking, and greatly appreciate that too, because we're very passionate here as well of what we're doing, and we know we're making some good.
Well, thanks again.
We'll be right back to Gut Punched, Alzheimer's and Caregivers.
If you find that it's time that you must start looking for a good home care company for your loved one, I'd like you to consider talking with Heart, Body, and Mind Home Care, a nationally award-winning company. They are top of the line in service. They will tell you service is their passion, excellence is their promise, and that's the honest truth. They are very knowledgeable and skilled at what they provide. On top of that, they are just really nice people who love helping others in need. They are Alzheimer's and dementia and Parkinson's care specialists. You can find them on the web at hbmhomecare.com, or you can call them at area code 239-603-6455. And you'll find a link for them on our website, GutPunched.com. Heart, Body, and Mind Home Care, your best choice for home care.
This is Gut Punched, Alzheimer's and Caregivers.
Looking ahead, we'll have part 2 of our conversation with John Huffaker from NPRC. And we're also working on a special music-focused episode, one that will be very interesting and very helpful when communicating with your loved one. Resources matter. If you're not sure where to turn or how to connect, we're here to bring you trusted resources that can lighten that load. Reach out to the Dubin Center at dubincenter.com. Then there is Neuropsychiatric Research Center. You can find them at NPRC, southwestflorida.com, and Heart, Body, and Mind Home Care at hbmhomecare.com. And you can check out the Alzheimer's Support Network at alzsupport.org. To find your local chapter of the Alzheimer's Association, you can visit their website or call their toll-free hotline at 1-800-272-3900. They also offer an outstanding resource called Dementia Care Navigation. It's powered by Ripple and the Alzheimer's Association. It provides free, personalized dementia care, including a dedicated care navigator and tailored resources for caregivers and people living with dementia. You can get connected by calling 855-271-2662 to get connected. That's 855-271-2662. Take the first step. We also mention the guide program frequently. It's another excellent resource that provides help and respite care, and it's free. You can search for it online or visit Dr. Perry's HealthSpan partners at healthspansouthwestflorida.com. Another resource worth checking out is Aquilane Clinical Research at aquilaneresearch.com. We've also added a couple of new books to our resource page at gutpunched.com. Our website is gutpunched.com, and the email address is gutpunchedac@outlook.com or jeff@gutpunched.com. Remember, you're not alone in this. There is help, there are resources, and there is hope. And thank you to each and every one of you who has taken the time out of your busy, stressful day as a caregiver to listen. We truly appreciate it. It's what keeps us going. Thanks for joining us. And if today gave you even a little hope, hold on to it. God bless.
This has been Gut Punched, Alzheimer's and Caregivers, with your host, Jeff Edwards. Don't forget to hit that like button and subscribe to us on all the platforms, like Spotify, Apple, Pandora, Podbean, and more. If you have a question or want to get in touch with us, our email is gutpunchedac@outlook.com or jeff@gutpunched.com. Caregivers, you don't have to do this alone.